So this is used. We use it in some of the general surgery cases, surgery or abdominal surgery cases, and this is also used in CTVS surgery. Okay. So there was a similar instrument which we have discussed in the first class, towel clip. Okay. It also works in the same mechanism, pincer mechanism of action. Because of the spring. Okay. So the spring is not working over here, but what happens is that when you leave it, it will bite the tissues like this without, and the spring is very soft, so that it will bite it just to occlude it without causing any injury to the tissues. Okay, so it will bite like this, and wherever any pedicles are there, like say in CTVS surgery, before tying out any vessel, or wherever any injury is there, so to repair, before repairing that, since bleeding will be happening from that large vessel, so to occlude that part which is coming out through that tear or through that injury, so we can put this instrument over there so that blood supply to that particular area is stopped and we can repair the vessel. Another use is when you're doing a Pringle maneuver. Okay, when there is any liver injury, when there is any liver surgery you're doing, to have an inflow control. Inflow control is the control of the vessels which are supplying the liver. Okay, that is your hepatic artery and the portal vein. So at the free border of the lesser omentum, what you can do is then you can put two bulldog clamps, and that will cause compression of these vessels which are supplying the liver without causing any injury to it, and thereby prevent the inflow of blood to this liver. So if any injury is there, what happens? The blood stops, so that now you can repair that injury. If you're performing any liver surgery, you can perform the surgery with this procedure. So usually whenever we do a Pringle maneuver, it should not be done for a longer period of time. 10 minutes of Pringle should be used, and followed by 5 minutes of, you should take out the Pringle. You should not keep it for longer time. Otherwise the liver can also undergo ischemic changes. Fine. Another surgery where it can be used is shunt surgery. Suppose you are doing a proximal sphenoidal shunt, a distal sphenoidal shunt. So we have cut the vein, but the blood will be coming through it. So what you can, at the before the end of the vein, what you can do, you can put this bulldog clamp, thereby preventing the blood and coming into the operative field. So what you can do is that then you can anastomose it with this renal vein. The splenic vein can be anastomosed with the renal vein, and then after the anastomosis is done, this can be removed so that the shunt starts functioning. Okay, so suppose this is the splenic vein. Okay, the renal vein also will be like this. So what is done in sphenoidal shunt is, this is after doing a splenectomy, the distal end of the splenic vein is anastomosed with the side of the renal vein, left renal vein. Okay, so this tip is now open. So here in this area, we can put this bulldog clamp like this. Okay, and then we can do the anastomosis. So after this anastomosis is done, we can remove it, so that now the pressure is more in this portal system. So from the splenic vein, now blood can go into the systemic circulation. Okay, so it is used in that also. Fine. So there's a bulldog clamp or a bulldog forceps. It is used to clamp mainly vessels in case of any injury while doing any anastomosis, and also it can be used for doing Pringle maneuver. Okay, Pringle. I hope everyone is knowing what is Pringle maneuver. Okay, so whenever there is any liver injury, or whenever there is you're doing a liver surgery, so as to decrease the intraoperative bleed, we can do this Pringle maneuver. Fine. It is also sterilized by autoclaving. Okay. Yeah, this is another instrument which is used by CTVS surgeons. It is rib Doyens rib respiratory. Okay, Doyens rib respiratory, RASPATORY. Okay, So what it is used for? So it is something related to the rib. Now rib has got a periosteum, and the neurovascular bundle of the rib is there on the undersurface or on the superior border of the rib, on the lower border of the rib. So it is attached to this periosteum. So before cutting the rib, we need to remove the periosteum of the rib. Okay, so what we do is that after giving an incision over the rib, suppose rib is like this, we give an incision over here like this, and then on the rib there is a periosteum will be then what we will do is that we put this so that it will lift the periosteum circumferentially like this, so that the entire rib will be now devoid of the periosteum, and then you can cut the rib or you can elevate the rib without causing any injury to these neurovascular structures. Okay, so you're taking out the rib, separating out the rib separately from the periosteum, thereby preventing any injury to this neurovascular structures. Okay, so whenever you are going to cut the rib or when you are going to handle the rib, then this instrument can be used. Okay, this is a rib raspatory. Fine. So it is used in CTVS surgeries wherever elevation of the rib is required or your cutting of the rib is required or needed. Okay. It is also sterilized by autoclaving. Yeah. So now there are some ortho instruments. Okay. Most of the instruments are very similar. So, okay. Now see this instrument. Sorry. Periosteal. Okay. Yeah, osteotome. Anything else? Okay, I'll give you three options: gouge, or chisel, or osteotome. Huh? Osteotome, gouge. So it's a bone gouge. Okay. The how will you differentiate it from these three instruments? Look very similar. So from far it is difficult to identify it. So you will see there is concavity on the blade. Okay, you see it is, you don't say it beveled, but there is a concavity, so that when you use it, some part of the bone is going to scoop, you're going to scoop out some part of the bone. Okay, so when you're going to resurface it, or when there is a notch in the bone, you want to level it, then this can be used. Or you want to take a bone fragment for some other purpose, then this can be used. Okay, so it is a bone gouge. Fine. So everyone is able to appreciate the concavity. Now, is it clear? It's slightly concave. You can see the surfaces. So that when you're going to apply it with a hammer, so some part of the bone, after resurfacing it, now it will also come into this area, and that part you can use it for some purpose, or it can also be used to take some biopsy from that bone. What they called as a notchplasty. They use it for notchplasty. Okay. It is also sterilized by autoclaving. Yeah. So what is this? Yeah. Chisel. Any other thing? It is a osteotome. Okay. So how will you differentiate? So you see, it is beveled on both the sides. From here also, from the under surface also it is beveled, and from the superior surface also it is. The blade is beveled, bi-beveled, we say it, on or two-sided beveled. You able to appreciate it? Okay, you see how it is curving, beveling on both the sides. Okay, this side and that side also. Can you? Everyone can appreciate it. Okay, so this bi-beveled instrument is a osteotome. Okay, this is used for cutting the bone. So when you are going to cut the bone, then we use this instrument. Okay. It is also sterilized by autoclaving. This one is chisel. Okay. It is one-sided beveled. It is beveled only on one side. Okay. You see, the lower part is straight and the upper part is beveled. The beveling is starting from here. Okay. At the tip only it is beveled. So it is used for resurfacing or smoothing the surface of the bone. Okay. So these three instruments everyone can differentiate now. Gauge will be having a concavity so as to accommodate some bone, so that you can take out a fragment or a larger fragment of the bone. Resurfacing is needed, larger, you want to remove more amount of bone, then that can be used. A chisel is one which is beveled on one side, so it is used only for surfacing the bone. Okay, just like a carpenter uses a chisel to surface for making the surface of the wood smooth, and the osteotome is used to cut the bone where it is beveled on both the sides. Okay. Yeah, this one. Yeah. Farabius periosteal elevator. Fine, that is correct. Okay. So here there are serrations you can see. That is for the. So that is the tip, okay, which is broken over here, but it will be even. Huh? And near the close to the blade there is some transverse serrations. This is used for the thumb rest. Okay, for the thumb to rest. So what you do is that if a bone is like this, you are going to rub it in this direction so that the periosteum gets stripped away from the bone, and then you can cut the bone easily. Okay, the periosteum is the outer covering which is slightly tough. So for you to it will be difficult for you to cut. So after lifting the periosteum, you can cut it easily. Fine. So this is the Parabius periosteal elevator. Okay, used for lifting the periosteum away from the surface of the bone. So wherever we are going to cut the bone, this one has to be done prior to cutting the bone. Okay. Fine. So whatever attachments are there to the bone, it is to the periosteum only. Like the muscles will be attached or the tendons will be attached to this periosteum only. So to remove these structures from the bone, you need to first use this one so that these structures are removed from that area, and then you can cut the bone. Fine. It is sterilized by autoclaving. Yeah, this one. Bone cutter or something else. Bone nibbler. Yeah. So what is the difference between bone cutter and bone nibbler? So when you see the blades, the nibbler will be something like to catch. Okay, you're going to catch it, and then when you turn it in one direction, you're going to break it. So it is used for nibbling of the bone. Like a bone has got some sharp, after the fracture has happened, there is some sharp edge of the bone, or you're doing some amputation, there is some sharp edge of the bone which is likely to injure the soft tissues nearby. So to make it even or make it smooth, we are going to catch hold of that sharp edge and break it. Okay, so that becomes smoother, and that way you avoid any injury to the nearby soft tissues when you close that incision. Okay, but a bone cutter, okay, usually used to cut small bones. Okay, so what will happen is that instead of like this, it will be just like a scissors. It will be looking like this, but this blade will be flatter. Okay, and it will be just like scissors. So it will be when you close it, instead of breaking any bone, it will cut it. Okay, it will be like a scissors. So this is a double action bone nibbler. Okay, so you can see this. There are multiple levers over here. Okay, one here, one here, one here. So what happens is that the presence of multiple levers minimizes the force needed to nibble the bone. Otherwise, bone is that tough structure that you have to use a large amount of force to nibble it or to break it or to cut it. So presence of this double action mechanism by the presence of multiple levers helps in minimizing the force needed for doing this procedure, that is nibbling of bone. Okay. Okay. Fine. It is sterilized by autoclaving. Yeah. Move on to neurosurgical instruments. Yeah, this one. Yeah, it is like a drill. The name is Hudson's manual drill or Hudson's brace. Fine. HUDSON. Hudson's brace or Hudson's manual drill. Okay. So what we do is that before that I will tell you these other instruments. This is a perforator. So whenever we are going to create a burr hole, we are going to use this instrument first. You see it is pointed. Okay, the tip is pointed. So whenever a burr hole is being done over the skull bone, so the skull bone is usually smooth. Okay, so initially what you're going to make is you're going to make an indentation in that. Okay, with the help of this one, and then after that, this spherical burr you're going to use it so that that indentation will prevent this from slipping. You see it is rounded, so it is likely to slip when you try to drill. Okay, so this first indentation and then using this one prevents it from slipping, and then that indentation can be drilled so that you can breach the cranium and enter into the intercranial cavity. You can do just a burr hole and drain some blood out of it. You can do some drain the ventricles whenever there is an increased intracranial pressure, or also you can do 2 or 3 burr holes, thereby connecting them each other, thereby doing a craniotomy. Okay, like 2 holes of burr holes are done, so you can pass one wire called a giggly saw. Okay, it's a wire which if we move it in to and fro motion, it will cut the bone. So through this 2 burr holes, we can pass a giggly saw and we can cut the bone. Like that, if we make 4 burr holes, or can be cut so that a square shaped cranium can be cut open, and so that we enter into the cranial cavity, we can do whatever neurosurgical procedures we want to do. Okay. So this is a spherical burr. This is the perforator, and this is the Hudson's brace. Okay, all are sterilized by autoclaving, and the use is during for making burr holes or for doing craniotomy, for carrying out any neurosurgical procedure. Okay, so how it is being held and how it is being attached, I'll just show it to you. So there is an opening over here. So you're going to fit it and then tighten the screw. There is one more screw. So this one you can tighten it. So it becomes like this then. So then what we do is that if this is the skull, okay, so you hold it over this and then you put pressure over here. Okay, so this is 2 points of contact, and then this one you have to rotate it. Okay, so after a few minutes, what will happen is that there will be indentation over the cranium because of this pointed nature of this burr. Okay, this perforator. After that, what you're going to do is that remove this one and use the other one. this one, and then drill it. Okay, so that there will be a point where there will be loss of resistance. That is that is where you have entered into the cranial cavity. Fine. So first you're going to use the perforator, okay, so that you make an indentation over the cranium, and then with the help of the spherical burr, you're going to drill it until there is a loss of resistance where we have entered into the intercranial cavity. Now two burr holes can be connected with the help of a Gigli saw. Similarly, if you make four burr holes, all those can be connected, and finally a square shaped or rectangular shape cranium can be, or a skull bone can be taken out, and thereby you can perform any neurosurgical procedure. Fine. So we have covered all these instruments. Okay. You can come here and see. For the next class, we don't have any classes actually. So if by chance some of the classes get postponed, so we can reschedule it on Wednesdays. Okay, because we have covered all operative surgeries, X-rays, instruments, and specimens we have covered. So we have completed our classes. What we can do is that if you're willing, we can do some clinical case presentations on Wednesdays. Okay. So you can, anyone can present, okay, and everyone can ask questions. Okay. Fine. If you're ready for that, we can do classes. Every Wednesdays we can do. Okay. Whoever is posted in surgery, they can also do. Who is not posted also, if you are able to do it, that is fine. Okay. Because I had heard from many that many of the times you're not getting consultants for taking class. So we can do it like that. And it's not that only me I will be coming for the class. You can approach any other consultant. If they are able to come at this time, then you can fix a class with them also. Okay. So you can convey this whether in the next class we are going to do or not with the help of your CR. Okay. You can take your time, decide, and let me know. Fine. It'll be good, or it'll be waste of time. It'll be good. No, there are some students who can study by their own, but there are what I feel is that the way you answer in the exams should be definitely be improved. You tell a lot of things, but the main thing you tell it in the last. Examiners might not be having the patience to listen that long, and they finally get an impression that no, you have not studied. Okay. So we can do classes like that so that you benefit from it. Okay. Sairam is here, or okay. When you decide, you can please convey it through your CR. Okay. You can, I think if you have on Wednesday classes, then Monday morning, once you finalize the case, you can speak to or talk to the concerned faculty who you would like to request for the class, so that he also knows that, okay, he has to come on Wednesday with the case. Okay. You not present the case to him, but you can tell that it's a case of, say, epigastric mass, or it's a case of inguinal hernia, or it's a breast lump, or it's a thyroid swelling. Like that you can tell, and approach that faculty so that you can have a case presentation case. Okay. Right. Yeah, it can be short cases also, but I feel that we have now a total of 13 classes are there till your all. I think after that your exams will be starting after that. So in 13 classes, you try to cover all the topics. Okay, if you're planning to do it, then try to cover all the topics so that everything is being covered. If you keep on presenting one topic, then it is of no use. Okay, so so that you get to know maximum number of questions, you try to note it down and prepare it accordingly. Fine. Questions will be asked whatever we are going to discuss over here. Huh. It's very rare that someone asks something else. Most of the questions you're going to get. So that is an advantage that you can note down those questions and you can prepare by yourself. Okay. And whenever you get a case, it will be easier for you. Fine. Okay. So you can come here and have a look at this instruments. Huh?